The EVO ICL has been approved to treat myopia of -3 to about -16 with astigmatism of up to 4 diopters. In patients with lower myopia, it's a wonderful option for those who have dry eyes or other at-risk issues such as form-fruste keratoconus or too thin corneas. In our practice, for those who have myopia of more than -6, we lean towards the EVO ICL as possibly a better option for those patients. Why do we do that? Because those who have myopia of greater than -6, the higher the correction you have, the more ablation of the cornea that needs to occur. With greater ablation of the cornea and the greater flattening that occurs as a result, there are many issues that can occur. The ablative nature of laser vision correction on the cornea can cause higher chance of dry eyes because there's more of a neurotrophic keratopathy that's associated with it. We also know that the more ablation you do of a cornea, you could potentially put that cornea at risk of developing ectasia. And someone who has more than -6, especially if their baseline corneal thickness is not sufficient enough to allow for a residual stromal bed of a certain amount, and we do all those calculations, so you don't need to worry about that. But we lean towards the EVO ICL to preserve the corneal integrity in those higher corrections. Again, to avoid the risk of ectasia and to help lessen the risk of dry eyes. There's also quality of vision that is of concern. And Arjan, what are your thoughts about that?
Yeah, great points made. And I would just add to that, in terms of quality of vision, when you're reshaping the cornea to a high degree, as we get when we do high ablations, it can lead to quality of vision issues, specifically with contrast sensitivity being reduced, and at nighttime, these patients sometimes can experience dysphotopsias that can be quite debilitating. These are those young patients who maybe they had a high ablation, and now they're complaining about oncoming headlights at night, they can't see, they don't feel safe driving. So for all of these reasons we've discussed, I think our preference is right around -6 to -8, depending on patient anatomy. We really tend to lean towards the EVO ICL.
The quality of vision in EVO ICL, there's no doubt, actually there's been studies to show in the higher corrections it's superior to LASIK. And also for those who have higher astigmatism, would you agree that the EVO ICL can potentially lead to better vision in a patient more than 3 diopters of astigmatism?
Yeah, I would totally agree. And it's a similar thing. It's, as you know, it just adds to the amount of ablation potentially taking place. And so if you have someone who's even a moderate myope, but they also have a moderate amount of astigmatism, that's no different than if they were just a high myope to begin with. And so I think just because the EVO ICL is so close to the nodal point for those high astigmats or high myopes, it really just is a fantastic option that gives very high quality vision.
And lastly, I think with the higher corrections, there's a higher chance of regression. And one of the benefits of EVO ICL, again, the cornea is left untouched. And so the risk of regression is far less than the higher corrections with the EVO ICL. And if there was to be any progressive myopia later in the life of the patient, you can always go back and do a small touch-up with LASIK. So that patient can then potentially continue to have excellent vision for many, many years. So there's no doubt that for high corrections, the EVO ICL in our practice is a superior option for our patients.